As we've said many times during the past 2 days, obesity and overweight Americans is a major problem in the United States. To discuss the topic of bariatric surgery, it's a pleasure to welcome to the podium two speakers. We have Dr. Yijun Chen, who is an assistant professor of surgery at UCLA, and we have Erik Dutson, who's a clinical professor of surgery at UCLA, the chief of bariatric surgery, and also the surgical director of the COMET clinic.
Good afternoon. Thank you very much to Dr. Kwan for inviting us to come and chat a little bit about obesity. I do have a complaint, though. Despite the fact that Dr. Ye is a friend and colleague, it's very challenging to speak after him. So forgive me, our presentation is good, but probably not as good as his. Anyway, we're going to talk a little bit about obesity today. We have a lot of slides, so I'm going to go a bit quick. We have no financial disclosures, and I'm going to take you back in time now, like Hot Tub Time Machine, to 1985, which I think, incidentally, is the same year as the movie. This is a distribution of obesity rates state by state in the United States, and this is from the CDC. I didn't make it up, and some of you may have already seen this, but when I hit the fast forward button on the United States, going from 1985, this is 1986, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96. Anybody notice a pattern? 97, new color. 98, 99, 2000, 2001, 2002, another new color. 2003, 2004, 2005, 2006, 2007. We have another new color. Colorado is holding strong. 2007, 2008, still holding strong. 2009, hanging on by its fingernails, but by 2010, even Colorado goes down. So this is frightening. Has anybody seen the movie Outbreak? This is happening right here around you. If this was a flu outbreak, you wouldn't be here because you wouldn't leave your house. Sadly, though, the distribution of diabetes over that same time course has matched basically 1 for 1, which is frightening. Now, if we look at the numbers here, overweight U.S. adults, 67%. 2 out of 3 people is either overweight or obese. Adults with frank obesity, 33 to 35%. Children, 17%. Healthcare cost is $168 billion estimated. And U.S. consumer expenditures for weight loss products, $50 billion. I think that's probably actually a conservative number. It's probably closer to $60 or $75 billion annually. Weekly deaths from obesity complications, greater than 6,000. So we're actually rivaling tobacco right now as potentially the #1 preventable cause of death in this country, and it's getting global, too. Now, historically, when you talk about obesity, people think this is a lifestyle choice, but then I have to ask you, even though we all think this and the media propagates it, it's sort of culturally acceptable to make fun of heavy people in many ways, who would choose to be obese? And I think that number is very small. So as a lifestyle choice, it's not really a lifestyle choice. It's historically been considered a characterological flaw. Stop eating so much. Currently, we think about things differently because we've been doing progressive science on it. We haven't figured it out, obviously, but we understand that the physiology, when we started to investigate this, is highly complex, highly complex. This is really an epidemic, and I think the slides from the CDC prove that. It's due to presumably changes in the modern environment. We haven't nailed down any one particular thing, but we do know there are multiple things in our modern environment that are very different. It's widely recognized now as a disease. The AMA recognized it as a disease last spring. There are a huge burden of associated illnesses, which I don't need to tell this audience about. It's a cause of more than 60 medical conditions, which include at least 12 different types of cancer, just from being overweight or obese. It also has, most importantly, a devastating effect on patients' quality of life. Part of the problem is, and maybe all of the problem, we may find out later, this is from the Nutritional Science Institute in San Diego, it's what we eat. Our modern food environment, our default food environment, if you look at what Americans eat as a share of a 2,100 calorie diet, 80% of calories consumed in the U.S. are from restaurants or consumer processed goods, and those goods have been highly altered. And the big thing that they're doing to it is slipping sugar in. If you go out of the country for a while and come back and eat our bread, it's going to taste like dessert sweet sugar bread. There's sugar everywhere, in everything that's processed in the restaurants and in the grocery stores. The other problem with this is that the consumption of these types of calorie-dense processed foods is much higher in lower socioeconomic regions. So it's sort of a double 1-2 punch. Now, how do you treat obesity? You guys treat obesity every day. 2 out of 3 of your patients is obese. Comprehensive lifestyle programs are probably the most successful approach. Behavior modification is critical. Dietary therapy is, of course, part of it. Exercise is an important component. Drug therapy is something that's being used a little bit more often. The FDA recently approved 2 new agents, which you're probably familiar with. And of course, the 800-pound gorilla is bariatric surgery. No sensible person wants to have surgery if they can avoid it, but the fact of the matter is, and we will develop this further, and Dr. Chen's going to talk more about it, is that bariatric surgery is highly effective. It's orders of magnitude more effective than everything else, and the fact is that in recent years it's become substantially safer, and we'll talk about that. So who should get surgery or treatment of any kind? If you look at the spectrum of treatment, who should get treatment? Patients who have a BMI between 25 and 29, that's probably most of us, right? So we consider that person not overweight, but in fact they are. They're considered low risk for developing comorbid problems. So they probably need to be counseled on weight gain and tell them to watch what they're eating and be a little bit more conscientious. BMI 25 to 29, but they have risk factors such as cardiovascular disease, hypertension, dyslipidemia, or if their BMI is a little bit higher without the risk factors, they're considered in the moderate risk category. They need a little bit more aggressive approach, counseling on weight loss interventions rather than just prevention of weight gain. They should be counseled on dietary items, physical activity, and some sort of behavioral modifications. Now, if you look at patients who have a BMI 35 to 40, they're considered high risk if they don't already have comorbid diseases. And if they're above 40, this is based on regression analysis that's been performed decades ago, they're very high risk. And that's why the BMI inflection points of 35 and 40 are what qualify people for surgery on the insurance markets. These folks need the most aggressive treatment. They need a major lifestyle intervention and/or surgery. What about comprehensive lifestyle programs? These include things like they combine diet, exercise, and behavioral treatment, therapy where needed. Behavior modification, the goal of behavioral modification is really to get patients able to undergo long-term behavioral changes. Now, that's very easily said and is rarely easily done. If it worked very well, then we wouldn't have to worry about obesity treatment because we'd send people to a therapist and then after a while they'd lose weight. But unfortunately, this is still a great challenge. What it is helpful for, if it's in the setting of a larger comprehensive program, it helps patients to understand what their cues and stimulus in the environment around them. Their 13-year-old kid who keeps bringing home F on his report card, who drives them crazy despite the fact that they need to tell them to study more, and then they go right to the refrigerator because they're so angry and they don't want to strangle their kid because that's considered a no-no. So things like this that we can all identify with, you know, your boss is a jerk or your spouse is driving you crazy, these are stimuli sometimes for people who have compulsive eating disorders, and it sends them to refrigerator to deal with it. Dietary therapy, all kinds of, which diet works? Well, the short answer is none of them work that great, otherwise everybody would be on the diet that works really well, right? I mean, we know that. That's why it's a $65 billion a year industry. But really, most diets work moderately, and it depends just on having some form of lower calorie and greater physical expenditure if you do that, but definitely below what your metabolic requirements are. So you can have a balanced low-calorie diet, low-fat, low-calorie, moderate low-fat, low-calorie, low-carbohydrate diets, Mediterranean diets. All of these things will actually work, at least in the short run. But if you're treating your patients and you put them on a diet and you think that, for the most part, they're probably being compliant, if they have less than 5% body weight change within 6 months, they really probably ought to be seen by an obesity specialist, whichever you choose. Exercise. Now, exercise is very important for an awful lot of reasons, but interestingly enough, exercise in a vacuum generally does not work very well for weight loss. In fact, it tends to drive up calorie consumption. But if you combine it with dietary restrictions, it actually has a synergistic effect. Now, the problem is patients. The patients who are morbidly obese, they will probably not respond with any sort of longevity to diet and exercise. And this was a publication that came out from Lancet Diabetes and Endocrinology this year, saying essentially if you have a morbidly obese patient, diet and exercise in the overwhelming majority of cases will be insufficient treatment. Drug therapy, okay, well, let's put them on some medications because we still don't want to send them to surgery. The classics that have been out for a while, phentermine and phentermine topramate, which is a new drug, Qsymia, you've probably heard of. Orlistat's been around for a little while. Belviq is one of the new ones from the FDA. And Contrave, which is a combination of naltrexone and bupropion. These are effective in lower BMI patients. Most of them can't be used uninterrupted for long periods of time. And the trouble is that when the patients stop the medications, they gain their weight back in most cases. Surgery. Again, this is the 800-pound gorilla in the room. What are the indications? I mentioned earlier that a BMI inflection point of 35 and 40 is what the insurance companies look at when they approve or disapprove patients for surgery. And that's based off of an NIH consensus conference from 1991. The publication reference here is from 1992, where it was, if patients already had a BMI of 35 with comorbid conditions, we knew that they were most likely to benefit from surgery and get the maximum yield out of it, which at the time was a fairly high-risk surgery. That number goes up to 40 even if the patients have no comorbid conditions, because they have a very predictable rate of developing comorbid conditions. So it's known that at these two BMI inflection points, the patient will gain the maximum benefit. So what's out there? There's been a lot of change in bariatric history. We've been doing it since the 1960s. We've learned a lot, and we've made a lot of mistakes. Currently, it's a very safe thing to do, but it hasn't always been. If you look at the options available in the United States right now, Roux-en-Y gastric bypass is still considered the gold standard operation because we've been doing it the longest. We know the most about it, but it does carry certain risks. Sleeve gastrectomy is the new kid on the block. It is currently the most frequently performed bariatric surgery in the United States. It's felt to be, by most people who have studied outcomes, to be slightly less effective in terms of overall weight loss, especially as patients get larger, but the resolution of comorbidities is basically identical. Adjustable band took off and failed. Adjustable band is less than 4% of bariatric procedures performed in this country right now. We've seen lots of problems associated with it. For any of you who are from the LA area, you were familiar with the 1-800-GET-THIN movement, and this was really, in many ways, I'm thankful for it because it's shown a light on the inadequacies of the lap band. V-Block is a new system that's just recently been approved by the FDA. It's a vagal nerve signal interrupter meant to modify satiety signaling or hunger signals to the brain. The intergastric balloon is something that was originally approved in the 1970s, but there's a newer, safer system that's anticipated to be approved by the FDA this spring. And the duodenal switch is one that's always been out there, but I put an asterisk by it because it's starting to make a bit of a comeback, because it was, when sleeve gastrectomy was originally done, duodenal switch, it was done as a first stage for a duodenal switch as a secondary stage. People saw that sleeve gastrectomy worked fine on its own, so it became a standalone procedure. But now we've found that patients who fail sleeve gastrectomy, that duodenal switch, a more modified and less severe version, is starting to gain traction. In fact, I just came here yesterday from our national conference back in Nashville this week, and the data that's being accumulated for this modified version of the duodenal switch is getting larger and larger and more compelling. This is what gastric bypass looks like. 94% of these operations are done laparoscopically nationwide. At UCLA, 100% of them are done laparoscopically. It's basically the creation of a small gastric pouch. Let's see if I can use this laser. Small gastric pouch here. We cut the intestine and bring it up to that part. This remains intact, the remnant stomach, and basically you get a combination of restriction and some hormonal alterations as a result of this operation. The food skips the first part of the GI tract, and it disrupts these hormonal communications, enteroenteric communications that have sort of gone rogue in the obese patient. If you look at the Swedish obesity study, this was published back in 2006, you can see from looking at this line that gastric bypass was really the most successful of any of the other options. And additionally, this is a longitudinal study that came out back then and looked at 15 years, and it has a durable effect by and large. Sleeve gastrectomy is less technically demanding for the surgeon. There are complications associated with the staple line, which can be severe, but if you look at the total possibilities for complications, they're much fewer with a sleeve gastrectomy, and because it does very well with resolution of comorbid conditions, it's become very popular, especially from the patients. The patients are asking for this. Challenge with this one, though, is it's irreversible because this part that we take out goes away. It's done laparoscopically also, virtually always, but you can't reverse a sleeve gastrectomy. This is what it ends up looking like afterwards. Once that piece of stomach goes out, it's gone. The advantages over a bypass, there are fewer different kinds of complications that can happen. The disease resolution is nearly identical, minimal nutritional side effects, and again, it's the most popularly performed, most frequently performed. Here's a picture of the lap band. I'm not going to talk much about this. It causes dysphagia, it's prone to complications, and you can predict with everyone who gets a lap band, even if they represent the 20% of patients who will do well with it versus the 80% that don't, all of those patients are going to end up with a secondary operation at some point unless they die with it in of unnatural causes. So there are significant disadvantages, and given the fact that it's only effective for about 20% of folks who get it in, it's been abandoned by most surgeons. The Maestro system, or V-block system I mentioned, is electrical leads. It's like a pacemaker that's put under the skin. Again, this is a brand new device, just recently approved by FDA, but essentially what you do is you put leads on the vagal trunks, and there's an electrical signal that disrupts the hunger sensation coming from the stomach. And their initial results are pretty encouraging. They're not on the same level as the other operations like duodenal switch, gastric bypass, gastric sleeve, but patients did have a maintain weight loss, good longevity. Intragastric balloon, same thing. This is really the role of this in the spectrum of treatment and the spectrum of surgery is not really clear right now, but it may serve very well in patients, say, who are 650 pounds and therefore too big for a laparoscopic operation. Perhaps the use of an intragastric balloon will decrease their weight sufficiently that they can get a definitive procedure done. Now, how do these things work? How do they work? If I knew the answer to that, I wouldn't be here. I would be receiving the Nobel Prize in Sweden right now, because we've known since the 1950s. This paper came out, I think, in 1955. We've known that patients who got partial gastrectomies for duodenal ulcers would have a resolution of their type 2 diabetes. Despite knowing for 6 decades that this happens, we have no clear understanding of why, but we have developed a much richer understanding of what's happening when we eat and what's happening in patients who are overweight. The mechanisms, the classic model was surgeons, I'll say, except for Dr. Chen and Dr. Ye, surgeons tend to be not very clever. We're simple. We're the transmission guy. We work on things mechanically. We figure if we shrink the stomach down and you can't get a Carl's Jr. hamburger in there, then you'll lose weight. Well, I wish it was that simple, because that's really not what happens. We always thought it was a question of restriction. That's why the lap band doesn't work very well. It was either restriction or malabsorption. Well, it turns out things like gastric bypass, even though there is a theoretic constriction component, patients can eat through it in 1 out of 6 will. And malabsorption, we don't really see that in gastric bypass. Really what we're looking at is altered GI signals to the brain. This is an endocrine, neuronal, enteroendocrine process that's being altered by food exposure changes, that the anatomical changes that surgery results in, and we don't fully understand those. It changes the GI signals to other tissues as well, like the pancreas and the liver and the adipose tissue itself. So this is what we're researching now. At COMET, this is what we're very focused on. If you look at some of the changes that we know about, and this is, again, a small fraction of probably what's really happening, you know, ghrelin modifies appetite. We heard about that probably a decade ago, and everybody said, oh, ghrelin, we're done. No, we're not. Ghrelin is one thing in a big chain of things. Things that decrease appetite are things like CKK, GLP-1, PYY, OXM. All of these are altered after bariatric surgery, and in ways that we can't always predict. So it's very interesting. Sleeve gastrectomy has similar changes for most of them too. So there's this concept of the foregut and hindgut and what signals are happening where. And it turns out, you know, something like the distal ileum in patients who've had bariatric surgery is getting an altered amount of bile content, and there's undigested nutrition that's coming to the distal ileum is signaling a braking mechanism in the central nervous system. Also, if you look, this is unpublished data out of the University of Cincinnati. If you look at the stomach itself, and you stimulate the mucosa of the lesser curve versus the greater curve. This is greater curve, this is lesser curve. And if you look at the gene expression from the cells in the mucosa, lesser curve versus greater curve, there is a huge difference. The greater curve and the fundus have 100-fold increase in gene expression with exposure to nutrients, and that's not happening in the rest of the stomach. The fundus and the body of the stomach are sort of the three-car garage storage units that expand greatly when we eat, and we know that hormonal signaling starts there just based on this alone. What exactly that signaling is, we're still working through. But that's critically important because the two operations that are most popular, gastric bypass and sleeve gastrectomy, involve altering nutrition exposure to those areas which are most genetically active during eating. What about neural responsivity and changes that we might see in patients who've had surgery? We know, for example, that patients have a significant alteration in their hunger and satiety system, and we know that they have a change in preference for the foods that they eat after gastric bypass surgery and sleeve gastrectomy. We know that after they have these operations, they suddenly don't want calorie-dense foods. They want to eat salads and stuff like that. And it's consistent and it's demonstrable on fMRI. And in fact, we have a couple of studies going on right now at UCLA looking at those changes. Another very exciting thing that we're looking at, not just in obesity treatment, but in every type of medical treatment for every problem in patients, is the role of the microbiome. And we know that if you take a germ-free mouse, they have a very difficult time maintaining their weight despite ingestion of high calories. If you give them a fecal transplant from a normal mouse, they will gain weight. So what the role of the microbiome in very simple explanations and probably the evolutionary significance of it is that it makes your extraction of energy from the environment more efficient. Okay, so there seems to be a natural role for it. But if you take a germ-free mouse and you give it the microbiome of an obese mouse, that germ-free mouse will become obese, even though they don't have a genetic predisposition to it. So something significant is happening at the level of the microbiome, and we haven't teased it out yet, but very interesting stuff. And the most interesting aspect of it, this was a study that came out 2 years ago, actually, from Dr. Kaplan's group at Harvard. If you take a mouse that is a knockout mouse for becoming obese, and you do a fecal transplant from a mouse that was obese but had gastric bypass surgery, take the gastric bypass mouse's microbiome, transplant it into the obese mouse, the obese mouse will lose weight without surgery. So this is a very, very interesting topic, and we're trying desperately now to figure out what the mechanisms are that work. But this is a highly significant piece of information. Now, I'm going to turn over the podium to my colleague and partner, Dr. Yijun Chen, who's going to talk to you a little bit about the clinical impact of obesity. Thank you, Dr. Chen.
Good afternoon. My name is Yijun Chen. I'm one of the bariatric surgeons at UCLA. My part of the talk is about the clinical impact of obesity and obesity treatment. When we are talking about obesity, to us, actually, the weight is not the most important part. The most important part actually is comorbidity, because obesity can induce a lot of comorbidities. Let's count from head to toe. So we can see that obesity can induce migraine, pseudotumor, hyperlipidemia, fatty liver disease, metabolic syndrome, type 2 diabetes, polycystic ovarian syndrome, venous stasis, gout. On the other side, from head to toe, depression, sleep apnea, asthma, cardiovascular disease, high blood pressure, reflux, urinary incontinence, joint pain. And many of you guys, or including me in the past, I didn't know was actually obesity can cause cancers. Then let's take a look at after rapid weight loss, usually with bariatric surgery, what's going to happen to those patients after anywhere between 50 to 250 pounds weight loss. And this is the data. This is a figure drawn by the people in Cleveland Clinic, Florida. What they showed here is that after bariatric surgery, migraine, 57% resolved. Pseudotumor, close to 100% resolved. High cholesterol, 63% resolved. Fatty liver, 90% improvement. Metabolic syndrome, 80% resolved. Type 2 diabetes, this is big. 83% at 1 year after surgery. 83% of the patients, they didn't need any medications. Polycystic ovarian syndrome, anywhere between 79 to 100% symptomatic relief. Venous stasis, 95% better. Gout, 72% resolved. Quality of life, this is very, very important for everybody. And our experience told us that 95% of the patients had significantly improved quality of life. About 90 to 95% of them told us that that was the best decision for them to have surgery in their life. That's the best decision they ever made in their life. And on this side, depression, more than half got better. Sleep apnea, anywhere between 74 to 98% improvement or resolution. Asthma, 80% better. Cardiovascular disease, up to 80% risk reduction. High blood pressure, 50 to 90% improvement. Reflux, 70 to 98% resolution. Urinary continence, 40 to 80% improvement or resolution. And very important, there was up to 78% reduction of cancer risk. And when we talk about the long-term survival and the long-term mortality, a Canadian study showed up to 89% reduction of 5-year mortality. Let's take a look at a few diseases. High blood pressure. We know that weight itself induces hypertension. It's very common for obese patients to have hypertension. Studies have shown that about 30 to 50% of the patients, they don't need any blood pressure medications after surgery. Another 20 or 30%, they had much reduced requirement for medications. High cholesterol. Large studies shown that one study from Utah showed about 50, 70 to 69% resolution of hyperlipidemia at 6 years after surgery. Another large study, LABS 2 study, showed 62% of the patients had remission of hyperlipidemia 3 years after gastric bypass surgery. Diabetes, up to at this point, there are probably more than 500 to 1,000 publications talking about weight loss surgery and diabetes. Almost every study showed benefit. The majority of the studies, they are retrospective studies. That's the reason that a few years ago, Cleveland Clinic did this large randomized trial, and they followed the patient for 3 years. So here is the data. So we can see that this is a medical management. This is a weight loss in terms of BMI. And initially, the patient lost some weight, but then they regained it back. And at 3 years, the loss of BMI was about 1. And the surgery group, we could see that the sleeve gastrectomy group, they lost BMI about 8. That's very significant. Gastric bypass surgery group, the BMI loss was about 10. That's very dramatic. Then let's look at HbA1c change. At the very beginning of this trial, everybody was trying hard. So even in the medical group, we could see that there was a significant drop of HbA1c at half a year. But with time, it goes back. It went back. How about the two surgery groups? At 3 years, both groups had a dramatic reduction of HbA1c. So the sleeve gastrectomy group, the A1C went from 9.5 to 7.0, and the gastric bypass surgery group, A1C went from 9.3 to 6.7. And we have to remember the surgery group, many of those patients, they no longer need any medications. How about the vascular complications from diabetes? This is one of the best studies done in Sweden. They had 20 years of follow-up. We could see that for the microvascular complications, at 20 years, there was about 50% reduction. How about the large vessel disease, stroke, heart attack? Again, it showed a decrease. We also need to know that so far, all the randomized trials showed that no matter what kind of medication you give to the patients, insulin, metformin, or other medications, it does not decrease the large vessel complications. This is the only study that has shown that a treatment, this is by surgery, can reduce large vessel disease complication from diabetes. This is a meta-analysis looking at heart attack after weight loss surgery. And all the 4 studies showed a benefit. When they combined the data together, there was about 50% reduction of chance of having heart attack after weight loss surgery. Another meta-analysis combined the data from 6 studies looking at the stroke risk. And when they combined the data together, they found that there was more than 50% reduction of chance of having stroke after weight loss surgery. NASH, this morning we just talked about NASH and fatty liver disease. It's one of the, at this moment, it's the 2nd common reason for having liver transplant in this country. In 10 years, when Hep C is gone, it's going to be the #1 reason for people to have liver transplant. And one study showed that inflammation and fibrosis were completely resolved in 37 and 20% of the patients with NASH. Another study, the fatty liver disease resolved in 89% of the patients after gastric bypass surgery. Cancer. Many of us didn't know that obesity and overweight can cause cancer. So here is the data. About 17% of the breast cancer is related to obesity or overweight, and 35% of the esophageal cancer. And shockingly, about 49% of the endometrium cancer is related to obesity and overweight. So for 4 studies, they try to establish a relationship between cancer risk reduction and weight loss surgery. This is what they found, and this is a meta-analysis. So again, when they combine the data together, they found about a 50% reduction of cancer-related, obesity-related cancer risk. Quality of life, this data is also from the Swedish study. We could see that this is a surgery group in the solid line. This is a medical management group. And after surgery, very soon after surgery, the patient had much better health perception. They had much less social problems, less problem with social interaction. They had much better overall mood, less anxiety, less depression. And very importantly, many of them, they don't feel hungry anymore. Obesity can also cause infertility in women. It's very, very common. Yeah. There was one large retrospective study from Italy. They had 110 obese patients who were unable to get pregnant before surgery. And after surgery, among the 110 patients, 69, so more than 50% of them, they were able to get pregnant without using any other methods. Sleep apnea, again, this is a meta-analysis. So we could see that for gastric bypass surgery, close to 80% of the patients had improvement or resolution of disease. This is even more dramatic for duodenal switch. And it's close to 99% of the patients had resolution or improvement of the disease. I think most people understand there's a huge benefit for bariatric surgery, but pretty much everybody is going to ask me, hey, is bariatric surgery safe? That's a great, great question. I would say if I'm answering this question about 20 years ago, I probably can't say that it is safe, because at that time, people were doing open surgery and were still at the early stage. There were lots of complications and even death. However, the key point I want to bring today is that over the last 10 to 15 years, the whole field has made a significant improvement in terms of safety. Let's just take a look at this data. From 2002 to 2009, this 8-year span, we could see that there was a more than 5-fold decrease of chance of dying from surgery. Let me ask the audience that, for example, everybody, most people here are PCPs. And if you have a patient with severe right upper quadrant pain diagnosed with biliary colic, you want to send this to a general surgeon for lap chole, remove the gallbladder. How many of you think this surgery is safe? Can you raise your hand if you think the surgery is safe? Okay, that's pretty good. And yeah, understand. Yeah, overall it's safe. Yeah. So let's say that if as another patient had severe hip pain, cannot walk, you need to refer the patient to have a hip replacement. How many of you guys think that overall the surgery is safe? Okay, that's good. Then you have a patient with BMI of 45 with diabetes, sleep apnea, high blood pressure, poor quality of life. You want to send the patient for weight loss surgery. How many of you think the surgery is safe? Much less. Yeah. So let's take a look at the data. It's very interesting. Okay, very, very interesting. So it turns out to be that in the United States, in this country, the chance for dying from a gallbladder surgery actually was 0.7%. Chance for dying from hip replacement surgery was 0.93%. And on the contrary, chance of dying from weight loss surgery was 0.1%. That means having weight loss surgery is 7 times safer than gallbladder surgery and 9 times safer than hip replacement surgery. Laparoscopic data, yeah. Yes. And nowadays, very rarely we have to do an open surgery. Yeah. To be honest with you, I don't know how to do open bariatric surgery, yeah, because I've never done one. I need to go back to 30 years ago to get trained again. How about now we know that surgery is safe. How about the risk of obesity? Actually, obesity is a killer. So let's take a look at 2 studies. One is from Dr. Adams' study. This is from Utah. They showed a 40% reduction of mortality, all-cause mortality. The Swedish study showed 29% reduction of mortality over the long term. And there was a Canadian study showed 89% reduction of mortality over the long term. This year, a few months ago, there was a new study came out from VA. They showed a 50% reduction of 5-year and 10-year mortality. Yeah. So it has been shown again, and again, even in the VA patients. Yeah. They are generally pretty old and very sick. So from this, I want to give a point is that because surgery is very safe and the risk of obesity is very high, nowadays I usually tell the patients that for morbid obese patients, not having surgery is much more dangerous than having surgery in the long term. Unfortunately, in this country still, even worldwide, there's still a very strong negative attitude towards obesity and weight loss surgery. Obesity most times is labeled as cosmetic problem or result of personal failure or lack of motivation. There was a study from Ukraine. They found that only 20% of the obese diabetic patients had a positive view regarding bariatric surgery. Nationwide, even though this surgery offers huge benefit, less than 1% of the eligible patients had bariatric surgery. Not only insurance is part of it, attitude is another major thing. For example, in California, I would say most insurance companies, they do cover bariatric surgery. Many of the PCP, when we talk to them, and they felt that the one thing they always tell us that I reserve bariatric surgery as the last resort. If I see a patient 250 pounds, 300 pounds, I ask them to lose weight themselves. Once they reach 400, 500 pounds, I send it to you guys. So what's wrong with that concept? So we know that the longer the patient had diabetes, the less chance that we're going to cure it with surgery. So we usually use the 7 years as a cutoff. If you had diabetes for less than 7 years, probably 90% chance we can cure it with surgery. If you had more than 7 years, it's probably 50% chance. It was the same for high blood pressure. Very interesting, there's just a recent study about a month ago. Many of you may have seen the news. They used a model. They used a huge database from Southern and Northern California, the Kaiser database, and there's a large HMO database. What they found is that a 45-year-old woman is the same for men. But let's just say a 45-year-old woman with diabetes and a BMI of 45, this patient gained about 6.7 years of life expectancy. However, a 30-year-old woman with diabetes and a BMI of 35, she actually gained 12 years of life expectancy. And this benefit went away when the BMI reaches about 62. So that means that when you see a patient at 250 pounds, 300 pounds, it's probably a time to make a referral. Don't wait they reach 400 pounds, 500 pounds, 600 pounds. Yeah. Because if they develop any organ damage from obesity, actually the window of opportunity is lost. Let me share with everybody what we have done at the UCLA because of this severe problem with obesity. Recently, under the leadership of Dr. Dutson, my partner, we formed this new center called Center for Obesity and Metabolic Health. We call it COMET. It is a multidisciplinary team with bariatricians, bariatric surgeons, hepatologists, interventional gastroenterologists, endocrinologists, and dietitians. Now we have a COMET clinic every Tuesday, and this clinic has 2 bariatric surgeons, 1 bariatrician, 1 hepatologist for the fatty liver disease, 1 dietitian. We combined the 3 programs at the UCLA together. The bariatric surgery program, there's a medical management program called the RFO program, and a healthier weight management program. So we told everybody within UCLA, for any of those management, they want to send a referral, they can just very easily type COMET in the Epic to do that. And that turned out to be very successful after we promoted this to our PCPs. One time we got like a 500% increase of referrals. But very soon we realized a problem I also want to share with everybody is that even after the PCPs made the referral, but more than 50% of the patients, they didn't come to see us. At one time point, it was a little bit humiliating, was about 70% of them, even after the PCPs made the referral, they didn't come to see us. Why? We realized that actually it's very important for the primary care physicians to talk to the patients, to spend some time to discuss them with these risks of obesity and the benefits of weight loss. You pretty much have to convince them that you got to do something. Otherwise, they're not going to come to see an obesity specialist. So in summary, obesity is a serious medical condition and disease for both men and women, not just a lifestyle preference. And bariatric surgery leads to durable weight loss, improved quality of life, and a decreased mortality in the long term. So it should be considered a safe option within the spectrum of treatment options. And a very, very important concept I really want everybody to bring home is that for morbid obese patients, especially those with comorbidities, not having weight loss surgery is more dangerous than having weight loss surgery in the long term. All right. Thank you very much.
Questions for Dr. Chen or Dr. Dutson?
I just have a question. A lot of patients, and this also goes back to our previous talk about narcotics and other things, is they always say, oh, I've had this type of surgery, I can't have NSAIDs. Can you comment on that and how long after it's okay?
Sure. So for anybody who didn't hear the question is, can patients take NSAIDs after they've had bariatric surgery? For patients who have room-wide gastric bypass, we advise them to never take NSAIDs for the rest of their life because the gastrojejunal anastomosis remains fragile lifetime. With the sleeve gastrectomy, we tell people not to take it for 6 to 8 weeks after the operation, but after that they can safely go back on it because what you have is the mucosa of the stomach is restored basically to its baseline.
Question for Dr. Dutson. I've heard a little while ago about some research that you can affect the ratio between white fat and brown fat. Younger people have more brown fat. They metabolize and burn up fat as calories better. Any news about that? And I also heard that the people that made Lorcaserin are coming out with a drug that's supposed to help you stop smoking and lose weight.
So, well, I don't know if it's to answer the second question first, I'm not sure if that's a new concept because it turns out that many of the SSRIs do both. And in fact, if you look at the Chantix and some of the available weight loss medications now, they do both. Because as you guys know, if somebody stops smoking, they gain weight almost immediately. So it's a big challenge. That's where you may preferentially choose to put them on an SSRI or one of the SSRI combo packets that will help address both issues. The first question about white fat and brown fat, unfortunately, brown fat's awesome. Brown fat has a super high metabolic rate. It actually helps you rev your metabolism and and it keeps us warm, actually, by burning. The trouble is that we have almost none of it after 6 months old. So that's the challenge. It's mostly actually in the mediastinum, and we don't see it much in adults. But there are groups that are working on ways that you can get cells to differentiate into brown fat versus white fat. It's a topic that I don't know a lot about because it's newish research, so I'm not as familiar as I should be, but I think it's exciting because if you could reprogram adipose to be brown, you wouldn't have any fat people left.
Can you address, have any studies done cost-benefit analysis of treating these patients since, you know, typical treatments for obesity have been so abysmal?
So
And
the question is, have cost analysis been done for bariatric surgery? That's actually a great question because if you look at the United States, and not just the United States, if you look at global health care, the return on investment for the cost associated with bariatric surgery is, in all cases, less than 3 years. In France, it's less than 1 year. So when we consider why insurance carriers, at least in California, I heard some grumbling from other states that insurance carriers don't pay for bariatric surgery, it's a massive cost savings. It's a massive cost savings to insurers, to the patients, and to society at large. The economic argument actually is almost as compelling as the quality of life argument.
I have a question. This is not to do with the bariatric surgery, but has anybody thought of a movement to make the food over here, the meat over here, which are the root causes of the problem, go more like organic? In other countries, you don't see that. What you eat is organic anyways.
Go ahead.
So there are lots of studies have done so far. Unfortunately, in this country, we are eating a very large proportion of the processed food. Yeah, it's very hard to change this environment, and you know, it takes a lot of effort to change the legislature. I don't think it's going to happen very soon to change the whole spectrum of the food we are taking. Yeah, it's sad thing that unfortunately we just can't change it in the short term.
What about this whole field of eating disorders and bulimia and all that sort of thing? How does this fit in with that subset of patients?
I can comment on that. So the question, if anybody didn't hear it, was how do eating disorders fit in with obesity management? And one of the things that we emphasize to our patients is that, especially with bariatric surgery does not cure eating disorders. It doesn't do anything at all to affect them that we know of. It's not been studied per se because most eating disorders fall within the spectrum of obsessive compulsive disorder, and if that's not treated ahead of time, especially after bariatric surgery, can really have devastating consequences. So that's, you know, before patients get surgery, they have to be screened by psychologists. In our program, we make the psychologist available to everyone. But the psychology and social interactions associated with eating, not just in this country but globally, are really profound. And if they are off the rails, they need to be put back on the rails before you can have any expectation of good treatment.
In this case, obesity is one of the leading cause of death. Yeah, obesity is the leading cause of death in this country. What do you think about, in terms of, you know, reducing death and challenge economic problems? What about prophylaxis bariatric surgery? What do you think about that?
Do you want to go ahead?
I didn't hear.
So the question was, what about prophylactic bariatric surgery?
Prophylaxis bariatric surgery. What do you think about that?
So
That will reduce the, you know, the economic.
So I, not to be too tongue-in-cheek, I don't want you to start throwing rotten lettuce at me up here, but as a surgeon, of course, I'm going to say that's the greatest idea I've heard in my career. But the fact of the matter is we are starting to reevaluate these inflection points in BMI and when we can expect to see the most benefit. For example, as Dr. Chen has told me many times, in Asian populations, especially Asians in Asia, the point at which they begin to develop severe comorbidities is at a much lower BMI than other parts of the world. For example, their incidence of diabetes jumping is at a BMI of 27, which for us, we think 27 is skinny. So because of that, we need to sort of keep an open mind about what the actual physiologic risks are and keep an open mind about when we should consider early surgery. But there are groups now who have tried to push that BMI level down to 30 to 35, In fact, the lap band has been approved for use in those groups, and there are groups within the bariatric societies who are pushing for sleeve gastrectomy, which is considered to be the safer between Roux-en-Y and sleeve, to be used at a lower BMI in diabetics.
Yeah, in many Asian countries, the cutoff for the surgery, the criteria actually was much lower. And in China, in some places, like BMI 30 and above, with diabetes, they can have surgery.
As primary care physicians, what should we be monitoring post-surgery, in particular laboratory studies and things like that?
So usually, most bariatric programs in this country, they see the patient 3 or 4 times a year within the first year. Every time they come to the bariatric surgeon, they usually have some labs. And after that, usually we just tell the patient that they just need to have the labs once a year. So pretty much looking at the vitamin deficiencies, that's the main thing, yeah. And also get the CBC and the CMP, that's pretty much it is. And nowadays with sleeve, we see much less nutrient deficiency than the bypass surgery. That's another reason that the sleeve is very popular.
But one additional point to that, thiamine. Keep an eye on thiamine, because we see that no matter what operation they've had, or even if they're on just a very aggressive diet, massive weight loss causes thiamine deficiencies, and thiamine deficiencies can present in a myriad different ways. And you'll have the patient show up in the ER and nobody can figure out what's wrong with them. If you know they've had bariatric surgery, just give them a gram of IV thiamine, their problem will go away. So thiamine is probably the most important. B12 is another commonly reduced one. Iron, calcium, and protein levels. Because sometimes these patients, because their food preferences do change so strongly, they'll stop eating any forms of protein. So that's something they need to be encouraged to do.
Okay, that will conclude the session. We will now take a break. Feel free to ask our speakers questions during the break. We'll reconvene at 3:20.